Today we're going to be discussing sustained acceleration and spatial disorientation from an introductory standpoint as the next lecture in our Aerospace Medicine Seminar Series. Thank you for joining us. This mini-series was originally developed as part of an integrated learning experience project for a master's degree at the University of Texas Medical Branch. This presentation uses material from the original mini-series and was updated in 2024. Our residency and associated projects are funded in part by NASA. The content in these presentations serves as a basic introduction to aerospace medicine concepts for students. It's not a substitute for formal ACGME accredited aerospace medicine training or aerospace medicine work experience and shall not be used as such in medical practice or decision making. This material, including text, images, and multimedia, is protected by copyright and other intellectual property laws. The content is provided for informational purposes only and may not be copied, reproduced, distributed, transmitted, displayed, modified, or otherwise used in whole or in part without the express prior written permission of the University of Texas Medical Branch at Galveston. The first topic I'll introduce today is sustained acceleration. We will cover the following objectives today as they relate to sustained acceleration. To understand sustained acceleration, we need to first look at how we measure it. A G, capital G, represents multiples of Earth's gravitational acceleration experienced by a human. Earth's gravitational acceleration is 9.81 meters per second squared. So the equation for a G is capital G equals lowercase a for acceleration divided by G, the Earth's gravitational acceleration. So for an example to put this into context, if you had a 70-kilogram pilot who's experiencing 3 Gs, what would that feel like to the pilot? It would feel like he's 210 kilograms. Now that we know what a G is, we need to talk about the directions in which Gs can be imposed on the human body. There are 3 vectors of Gs, Gx, Gy, and Gz. Each of these directions has a positive vector and a negative vector. These figures illustrate the positive vectors. The best way to remember this is through something called the left hand rule. Using your left hand, make your thumb, index, and middle fingers all point 90 degrees from one another. To do so, you're going to point your thumb and index finger like you're shooting a rubber band. Then flex your middle finger to 90 degrees so that it's pointing to your right. Now look at your hand. The thumb represents positive Gz. It's pointing up. The index finger represents positive Gx. It's pointing forward. And the middle finger represents positive Gy. It's pointing to the right. These are all in relation to your body as the human subject experiencing the Gs. Knowing that those are the positive directions, the opposite directions are negative. So down represents negative Gz, backwards represents negative Gx, and to the left represents negative Gy. Gx, the front to back plane, as we illustrated using the left-hand rule, is what humans tolerate best. That's to say that the human body can tolerate the most Gs in the Gx plane, specifically positive Gx acceleration. You may have heard of G-induced loss of consciousness. What is it? It's possible for humans to experience so much G, specifically positive Gz, that they lose consciousness. From the left-hand rule that we learned on the last slide, positive Gz is the thumb, which is the upward direction. So the movement of the vehicle is upward with positive Gz acceleration, and the human in the vehicle subsequently feels smashed down into their seat. The blood in the human is also smashed downward, resulting in pooling in the lower extremities. If this happens, then not enough blood's getting to your brain. When too little blood gets to the brain, it becomes hypoxic and loss of consciousness will result. Incidentally, the blood also pools in the lungs, resulting in the top half not perfusing at all above positive 3 Gz, leaving the lower half responsible for all perfusion. There's a standard progression to G-induced loss of consciousness, or G-LOC as it's called. The first manifestation is tunnel vision. This is a dimming of the peripheral vision. The next is gray out. This is when color vision is lost. Next is blackout, or complete loss of vision, although the person is still cognitively aware of their surroundings. Next is ALOC, which stands for almost loss of consciousness, which is a transient incapacitation, but without complete loss of consciousness. Last in the progression is G-LOC, which is, of course, as the name indicates, loss of consciousness. So clearly it's a safety issue to have aviators experiencing G-LOC. So how do we avoid it in aerospace medicine? There's 4 main categories of avoidance measures that we use. The first is to limit exposure and duration of maneuvers that put an aviator at risk. The second is to decrease the vertical distance between the heart and brain. The third is to avoid something called the push-pull effect, which we'll describe in a few minutes. And the fourth is to increase blood pressure at the level of the aortic valve. So first, we'll talk about decreasing the vertical distance between the heart and brain. You can see from this shuttle era picture that when crew members take off for space, they lay on their backs. Why? Because we're decreasing the vertical heart-brain distance. By lying on their backs, we're essentially making the vector Gx, left-hand rule. Remember, that's the index finger. So now they're experiencing all of the acceleration in the Gx direction instead of the Gz direction. Another strategy is to avoid something called the push-pull effect. The push-pull effect is named by the inputs that an aviator uses on the controls. Pushing in on the controls causes the aircraft to dive, and pulling back on the controls causes the aircraft to climb. Push-pull effect is exactly what it sounds like, pushing down on the controls to dive, followed immediately by pulling back on the controls to climb. Avoiding this can decrease incidence of G-LOC. The push-pull effect itself is responsible for about 30% of high-performance aircraft G-LOCs. Why is it a problem? When the aviator is experiencing negative GZ during the push, they get a parasympathetic baroreceptor response, which results in bradycardia and vasodilation. Then when they subsequently pull and experience positive GZ, now the blood is pooling, as we talked about previously, but it's pooling in vasodilated lower extremities, which is you're starting off in a hole, right? And the recovery is prolonged as a result, which can result in G-LOC. Another strategy to avoid G-LOC is to increase blood pressure at the level of the aortic valve. The most effective way to do this is through the use of an anti-G straining maneuver. Anti-G straining maneuvers utilize Valsalva techniques and tensing of the limbs and abdomen in conjunction with forced exhalation against a closed or a partially closed glottis. By doing this, intrathoracic pressure is increased, thus increasing blood pressure at the level of the aortic valve. The maneuver is held for approximately 3 to 4 seconds, and then a very rapid expiration and inspiration follows. The rapid expiration and inspiration ensures adequate venous return during this brief decrease in intrathoracic pressure. It's critical that the inspiration-expiration is less than about a second, though, so that you can return to a state of increased intrathoracic pressure, thereby avoiding loss of consciousness. The anti-G straining maneuver is an important skill for aviators and is practiced in the centrifuge environment. I would encourage you to search the internet for centrifuge videos. There are many available online, and they illustrate the use of anti-G straining maneuvers, and many show G-LOC. Additionally, a G-suit can also be used to increase blood pressure at the level of the aortic valve. It's a garment worn by the aviator that has pneumatic pressure bladders inside of it, typically over the abdomen, thighs, and calves. Pressure to the bladders is increased as positive GZ maneuvers increase automatically. Peripheral total resistance and venous return are increased from the compression supplied by the bladders. When both an effective anti-G straining maneuver and a G-suit are used, the G tolerance of a pilot can be increased by about 4 to 5 Gs. Resting G tolerance in a healthy military aviator is approximately 5 Gs. So in total, with the use of the G-suit and an anti-G straining maneuver, military aviators can achieve about a 10 G tolerance. That was a brief, very high-level introduction to sustained acceleration and some of the concepts that we think about in aerospace medicine. Now let's switch gears and discuss spatial disorientation. We'll cover the following objectives as they relate to spatial disorientation. First, let's look at some spatial disorientation statistics to appreciate the scope of the issue and why it matters. According to the Federal Aviation Administration, 5 to 10% of all general aviation accidents involve spatial disorientation, and of those accidents, 90% are fatal. Based on accident investigation research from the Air Force, the stereotypical aviator is a male fighter pilot approximately 30 years old, has 10 years of experience, and 1,500 hours as a pilot in command or instructing. This is worth mentioning. This is not an inexperienced aviator. Furthermore, It isn't an aviator whose currency has lapped. The stereotypical airman has flown 25 times in the 3 months prior to the accident. Unfortunately, spatial disorientation accidents cost the Air Force more than $500 million every 10 years. There are 3 types of spatial disorientation. Type 1 is unrecognized. In other words, the pilot doesn't realize that they're disoriented. This is very dangerous. It's the most common cause of accidents due to spatial disorientation. Type 2 is recognized. The pilot knows that something's wrong, but may not be able to recover. This is the second most common cause of mishaps due to spatial disorientation. Type 3 is incapacitating. The aviator knows that something's wrong, but they're so disoriented that they're incapacitated and can't perform corrective maneuvers as a result. This is the least frequent of the 3 types. So how does this happen? Before we can appreciate how we become disoriented, first we need to understand how we're usually orienting to the surroundings in aviation. The visual system is responsible for 90% of orientation. The vestibular system provides the remaining 10%. Despite this, about half of spatial disorientation accidents are the result of the vestibular system and half visual. The reason for this will become apparent in the following slides. The vestibular system has 2 parts, the semicircular canals and the otoliths. There are 3 semicircular canals, each of which corresponds to an axis of motion in flight. The canals are depicted in the image on the right of the slide. The anterior vertical canal corresponds to pitch, the posterior vertical canal corresponds to roll, and the lateral horizontal canal corresponds to yaw. The semicircular canals provide information to the brain about angular motion. They act like angular accelerometers. The otoliths, on the other hand, act like linear accelerometers, providing proprioception for tilt and linear motion of the head. We just introduced that there are 2 main systems for orientation, visual and vestibular. First, we're going to dive in a little deeper into visual illusions and the visual system, and then we'll transition to the vestibular illusions. First, I'd like to talk about something called size constancy, which has implications for illusions when landing on runways of different widths.
Runways with varying widths and lengths are another source of illusions that may affect your perceived glide path. An approach to an unusually narrow or long runway may produce the visual illusion of being high on final approach. If believed, you may respond by pitching the aircraft nose down to decrease your glide path, which, if performed too close to the ground, may result in an accident. An approach to an unusually wide runway may produce the opposite illusion of being low on final approach. If believed, you may respond by pitching the aircraft nose up to increase glide path, which may result in a low altitude stall or a missed approach.
Here you see next to the letter A, a normal runway. This is the image that the pilot is trained to see out of the cockpit when they're on final approach. They know when the runway looks like this, they are neither too high nor too low. I've now added a second runway labeled B to the image. It's a narrow runway. Compared to the image of runway A, do you look too high or too low? You look too high. If pilots have the illusion that they're coming in too high, they can falsely compensate and unintentionally come in too low on landing. Looking at the diagram to the right of the runways now, you can see that the dotted line is the glide path that the pilot should be taking, and the solid line is the glide path that the pilot inadvertently takes, compensating for the illusion. If pilots come in too low, they can land short of the runway, or they can have hard, dangerous landings. Let's look at a real runway. You can appreciate looking at this runway that you look high. The reason for that is because this runway is narrow. What about a wide runway? I've added a runway labeled C to this picture. Looking at C, pretending you're the pilot in the cockpit on final approach, do you look too high or too low? If you said too low, you're correct. Adding the graphic of the compensation by the pilot, we can see that the pilot feels too low and compensates by coming in too high and flaring too early. During the flare, you lose lift. This will result in dropping from that height onto the runway. Again, the dotted line is the glide path that the pilot should be taking, and the solid line is their compensation due to the false perception. So again, looking at an image of a real runway, you can appreciate that with this wide runway, you now look low. Altogether, when the runway is narrow, there's a tendency to feel like you're too high and incorrectly compensate by coming in too low. And when the runway is wide, there's a tendency to feel like you're too low and incorrectly compensate by coming in too high, putting the pilot at risk for flaring too early. We just looked at size constancy. Now let's look at shape constancy. Shape constancy is the tendency to perceive the shape of a rigid object as constant despite differences in the viewing angle. This causes illusions with sloping runways.
Which lines are the same length? Are the thin lines parallel to each other or crooked? How much longer is line A than line B? Which side of this cube is in the front and which is in the back? It depends on whether you look at A or the B. Many visual illusions can occur and cause you problems during the takeoff and landing phases of flight. You learn to recognize a normal final approach by developing and recalling a mental image of the expected relationship between the length and the width of an average runway, surrounding terrain, and geometric shapes. Some factors that can create landing illusions are runway width and/or length, runway slope, surrounding terrain, fog and haze, smooth, solid surfaces, runway lighting. A final approach over flat terrain with an upsloping runway may produce a visual illusion of being high on final approach. If you believe this illusion, you may respond by pitching the aircraft nose down to decrease your glide path, which, if performed too close to the ground, may result in an accident. A final approach over flat terrain with a downsloping runway may produce the visual illusion of being low on final approach. If you believe this illusion, you may respond by pulling the nose up to increase the glide path. This action may result in a low-altitude stall or missed approach.
Let's break down those illusions and look at them in more detail. Depicted on this slide is a level runway. This is ideal. The image on the runway on the left labeled A is as though you're landing the aircraft in the cockpit, just like the previous images that we saw. You're on final approach. This is what you would see looking out the window. I've now added a runway image B. On image B, do you feel like you look too high or too low? You're correct. You look too high. So adding the graphics on the right, you can see that with this upsloping runway, the pilot feels like they're too high and can incorrectly adjust their flight path, as was mentioned in the FAA video. If the pilot feels too high, but importantly is not too high, they can push the nose of the aircraft down in an effort to lose altitude. This will result in coming in too low for the landing. The dotted line is where the pilot should be, whereas the solid line is how the pilot incorrectly adjusted due to the illusion of being too high. This can result in accidents on landing, including falling short of reaching the runway. So again, let's look at a real runway instead of a graphic. This is an image of an upsloping runway. Again, the illusion is of being too high, so pilots have a tendency to come in too low to compensate for the illusion. I'll have you note that where the arrows are at the beginning of the runway is not technically where you are meant to land. You are not meant to land until after the solid white line. You can see from the tire tread marks that many pilots have landed short of the beginning threshold of the runway due to this illusion. So what about a downsloping runway? Again, The graphic at the top runway, next to A, is your ideal level landing. The bottom image, labeled C, represents a downsloping runway. Do you look higher or lower than the top image? You are correct if you said lower. Adding our graphic of the airplane and the runway to the right. On this downsloping runway, you look too low. So pilots can have the tendency to compensate by pulling the nose of the aircraft up and being too high on landing. Again, the dotted line is where the pilot should be, but because of the illusion of being too low, they can have a tendency to incorrectly compensate and come in too high, depicted by the solid line. This can again result in crashes on landing. If the pilot fails to add power when they pull the nose back, they can stall the aircraft. Stalling occurs when there's no lift, which means the plane will fall to the runway. So let's look at an image of a real downsloping runway. You can appreciate that you look low. So again, if pilots feel too low, they have a tendency to compensate by coming in too high.
The runway illusions that we just discussed were the result of size and shape constancy, which is based on visual input. Now, let's switch gears and discuss illusions caused from vestibular inputs. First, we will discuss the graveyard spiral. The graveyard spiral is a somatogyral illusion caused by the semicircular canals. Imagine a pilot in poor weather conditions so they cannot rely on visual cues. The graveyard spiral occurs when the pilot is turning at a constant rate for more than 20 seconds. The vestibular system reacts to changes in direction. So at a constant rate of turn, the vestibular system will essentially reset, and the pilot becomes unaware that they're still turning. When the pilot exits the turn, the vestibular system senses the change in direction and erroneously makes the pilot feel as though they are now turning in the opposite direction, instead of leveling off as they're actually doing. To compensate, the pilot re-enters the turn because this feels correct based on the vestibular inputs. Unfortunately, despite feeling correct, the plane is spiraling towards the ground. Let's see what happens if the pilot doesn't recognize this illusion on the next slide. This is a video from the Civil Aviation Safety Authority in Australia.
Runway 35, clear for takeoff.
The sky is overcast and the visibility poor. That reported 8-kilometer visibility looks more like 3, and you can't judge the height of the cloud. Your altimeter says you're at 1,500 feet, but your map tells you there's local terrain as high as 1,200 feet. There might even be a tower nearby, because you're not sure just how far off course you are. But you've flown into worse weather than this, so you press on. You find yourself unconsciously easing back just a bit on the controls to clear those non-too-imaginary towers. With no warning, you're in the soup. You peer so hard into the milky white mist that your eyes hurt. You fight the feeling in your stomach. You swallow, only to find your mouth dry. Now you realize you should have waited for better weather. The meeting was important, but not that important. Somewhere a voice is saying, you should have turned back. You now have 178 seconds to live. Your aircraft feels on an even keel, but your compass turns slowly. You push your rudder pedal and add pressure to the controls to stop the turn, but this feels unnatural, so you quickly return the controls to their original position. That feels better, but now your compass is turning a little faster and your airspeed is increasing slightly. You scan your instrument panel for help, but you don't find any. It all looks unfamiliar. You're sure this is just a bad spot. You'll break out in a few minutes. But you don't have a few minutes. You now have 100 seconds to live. You glance at your altimeter and are shocked to see it unwinding. You're already down to 1,200 feet. Instinctively, you pull back on the controls, but the altimeter still unwinds. The engine is into the red, and the airspeed's almost there too. You have 45 seconds to live. Now you're sweating and shaking. There must be something wrong with the controls. Pulling back only moves that airspeed indicator deep into the red. You can hear the wind tearing at the aircraft. You have 10 seconds to live. Suddenly, you see the ground. The trees rush up at you. You can see the horizon if you turn your head far enough, but it's at an unusual angle. You're almost inverted. You open your mouth to scream.
The video that you just watched may seem like a dramatization, but the panic in that situation would be very real. Let's look at the graveyard spiral depicted graphically and break it down. The white circles on this image are what the pilot perceives, whereas the other images of the aircraft are what the pilot is actually doing. At position 1, the pilot is turning at a constant rate. At position 2, the constant rate turn has continued long enough that the pilot's vestibular system now thinks that the pilot is level again. This is indicated by the white bubble with a level aircraft in it. The pilot perceives that they are level. Between position 2 and position 3, as indicated by the colored line, the pilot is turning the yoke in the opposite direction. This would result in actually leveling the plane off and coming out of the turn. However, as indicated by the white perceived bubble to the left of position 3, since the pilot felt like they were level before this turn, they now feel like they are turning in the opposite direction instead of leveling off. This is an erroneous illusion that the pilot feels, that they're turning in the opposite direction instead of leveling off. So the pilot returns to the original turn, which still feels like the plane is straight and level. This is position 4. This results in a downward spiral. So what happened there? Why did the vestibular system send such a false signal? When the aircraft, and thus the head of the pilot, turn, the semicircular canal moves with the pilot's head, but the fluid inside does not move initially because of its inertia. Depicted by letter A on this slide, as the semicircular canal moves, the hairs inside move with it and are bent in the opposite direction of the acceleration by the stationary fluid. This sends a signal to the brain to indicate that the head has turned. This is normally not a problem. But if you turn at a constant rate for 20 seconds or longer, as depicted by letter B of this slide, the hair cell becomes upright again because of the constant rate of the turn. Essentially, the fluid inside catches up to the rate of the movement of the head, so the hair cell is stationary. Now, as depicted by letter C, when you come out of the turn, angular deceleration, the hair cell goes the other way and makes you think that you're turning, even though you're leveling off.
The somatogyral illusions concerns false sensations about the magnitude and/or false perception of rotation in its actual absence. The graveyard spiral and spin, due to somatogyral illusions, are two of the oldest in aviation. The semicircular canal is activated when you accelerate rapidly into a turn, in this case a left turn. The fluid within the semicircular canal lags behind the accelerated canal walls and bends the hair cells to the right, or in the direction opposite that of the imposed acceleration. The brain interprets the movement of the hair cells to the right as angular movement to the left. If the turn continues at a constant rate for several seconds or longer, the motion of fluid catches up with the canal walls. The hair cells are no longer bent, and the brain receives the completely false impression that turning has stopped. When you return to level flight, the fluid inside the canal will continue to move during the rollout, and even for a while after the turn stops. This will send a signal to the brain indicating that you are turning in the opposite direction, an illusion. You can observe this reaction by using a Barony chair to simulate a constant rate turn. Blindfold or place goggles on a pilot to deprive the subject of visual cues and secure them in the Barony chair. The subject is then told to indicate the rotation of turn by using thumb signals. As the rotation begins, the subject is aware of the movement. But will gradually lose the turning sensation as the fluid catches up to the rotation. As the chair is brought to a sudden stop, the canal fluid continues to move for a short period of time, and the hair cells are bent to the left. This gives the subject the illusion of turning opposite the original direction. If this sensory illusion is believed, you may try to counteract it by inappropriately turning the aircraft in the original direction. Now,
Let's look at another illusion caused by semicircular canals. It's called the Coriolis illusion. The Coriolis illusion occurs when two semicircular canals, which recall are oriented in different planes to each other, are stimulated at the same time. This can occur when the pilot is turning the aircraft and looks up or down.
The Coriolis illusion is probably the most dangerous of the vestibular illusions. This illusion involves the simultaneous stimulation of two or more semicircular canals in each ear, as is associated with a sudden tilting of your head, forward or backwards or to the side, while the aircraft is turning. This can occur when you tilt your head down to look at an approach chart or to write a note on your knee pad, or tilt it up to look at an overhead instrument or switch. This produces a very incapacitating sensation that the aircraft is rolling, pitching, and yawing all at the same time. This very uncomfortable illusion can make you become airsick or may result in losing control of the aircraft. To prevent this reaction, avoid sudden extreme head movements while making turns.
Let's move on to another vestibular illusion. It's called the head-up illusion. Unlike the other vestibular illusions that we've discussed so far, this illusion is caused by the otoliths and pertains to linear acceleration rather than angular acceleration. During rapid acceleration, the otoliths can send a false sensation that the aircraft is climbing. The opposite is true during rapid deceleration. A good example of this is a jet aircraft taking off of aircraft carriers. They accelerate so quickly that there's a profound sense of climbing, almost feeling like you're climbing vertically. This feels like too steep of a climb, and as a response, pilots will push the stick forward to try to make the climb less steep. There have unfortunately been cases of pilots crashing into the ocean as a result. This is such a profound sensation that the Navy has a policy that pilots have their hands up on the canopy when they take off to prevent the urge to push the nose down.
To prevent this reaction, avoid sudden extreme head movements while making turns. The otolith organs are located in each ear at the base of the semicircular canals. The otoliths detect changes in linear acceleration in the horizontal plane and changes in the position of the head in relation to gravitational forces. Their structure consists of small sacs covered by hair cell filaments. These filaments project into an overlying gelatinous membrane tipped by tiny calcium stones. Let's observe this organ and how it operates. The sensory hairs will deflect with a change in your head position due to gravity acting upon them. So when you tilt your head, the resting frequency is altered and the brain is informed of your new head position in relation to the vertical plane. The biggest problem occurs when there is exposure to linear acceleration, such as during takeoff or landing. During takeoff, with sufficient forward linear acceleration, the fluid will flow over the otoliths and send a signal to the brain, inducing a false sensation of over-rotation. This illusion would tell you to push forward with the controls regardless of aircraft attitude. This would cause the aircraft to nose over and possibly crash.
We've talked a lot about spatial disorientation and illusions that can occur. Often, students in my class at this point think that hope is lost and everyone will succumb to spatial disorientation. This is not true. Hope is not lost. Spatial disorientation can be overcome. Ways that it can be overcome include pilot training, awareness, recognition, avoidance of maneuvers that would set them up for spatial disorientation illusions, and as you can see on the right here, trusting the flight instruments. I cannot emphasize that enough. There is nothing wrong with the aircraft. It is an illusion. So trusting the instruments will get you out of the illusion.
So now it's time for a knowledge check to see what we've learned. Question 1. Regarding the picture below, which direction of G is depicted? A. GW, B. GX, C. GY, or D. GZ? The correct answer is D. GZ, or head-to-toe axis. Using the left-hand rule that we learned in this presentation, this would be the direction that your thumb is pointing. Question 2. Humans tolerate which direction of G the best? A. GW, B. GX, C, GY, or D, GZ? The correct answer is B, GX. Humans best tolerate acceleration forces in this chest-to-back direction. Question 3. A common mistake when landing on an upsloping runway, that is, the runway is lower at the beginning and higher at the end, is to be lower than desired when attempting to land. True or false? The correct answer is true. Remember, if you feel too high, but importantly, you are actually not too high, you will push the nose of the aircraft down in an effort to lose altitude. This will result in coming in too low for your landing. Question 4. When taking off from an aircraft carrier, pilots often feel as though they are climbing vertically, and multiple pilots have crashed into the ocean as a result of their attempts at compensating. True or false? The correct answer is A, true. This is known as the head-up illusion, as discussed earlier. This illusion is caused by the otoliths and pertains to linear acceleration. During rapid acceleration, the otoliths can send a false sensation that the aircraft is climbing too steeply. As a result, pilots may push the stick forward to try to make the climb less steep. There have, unfortunately, been cases of pilots crashing into the ocean as a result. Question 5. When a jet pilot experiences positive GZ, which portion of the lungs is responsible for the most gas exchange during this maneuver? A, apices, B, bases, C, posterior, D, anterior, or E, lingula? The correct answer is A, apices. An example of positive GZ is taking off in a rocket. The vector of acceleration is up, and the human feels like they are being smashed down into their seat in response. Accordingly, their tissues experience the same effect, and the bases of their lungs would experience more alveolar compression than the apices.
Thanks for your time and attention. That's the end of the lecture. Here's the references for the images, videos, and content in this presentation. I would like to point out numbers 4 and 5. Throughout this presentation, small snippets of spatial disorientation videos from the FAA were presented. The entire videos can be found at the links for references number 4 and 5. Each video is about 15 minutes, and I would highly recommend watching the entire video for both part 1 and part 2. Thanks very much. Have a great day.
We'd also like to give special thanks to Dr. Amy Krakis, UTMB RAM graduate, class of 2020, who created the original version of the UTMB Aerospace Medicine Seminar Series. And special thanks to Ms. Heather Medley for her tireless work in reformatting and updating the seminar series as part of the 2024 revisions. Thank you for watching this presentation. We hope that you enjoyed it. If you have any questions, please don't hesitate to contact us at the email listed here.